Good morning. This morning I'm reporting on our study investigating the oral health of people living with motor neuron disease. This project was motivated by our observation of poor oral health in our MND patients. We started by completing a comprehensive review of the literature to investigate if oral health is reported to be a problem in people living with motor neuron disease. If so, how should we be assessing the oral health of our MND patients? And what are the best oral hygiene practices to promote good oral health? Throughout this presentation, I'll refer to oral health as the absence of active disease in the mouth, and oral hygiene as the practice of keeping the mouth clean. Our literature search regarding the oral health and hygiene in MND provided us with very limited information. There are a small number of general opinion-based guidelines for oral hygiene, but we weren't informed about whether oral health is a problem for MND patients, how we should be assessing it, and what are the best oral hygiene practices to be encouraging in our patients. We know from studies in other adult neurological populations that people with MND are likely to have poor oral health. For example, elderly people with impaired cognition are more likely to report oral health problems compared to elderly people with normal cognition. For people with physical difficulties, poor oral health is more common. For patients with Parkinson's disease who have hypokinesia, oral health is more likely to be a problem than Parkinson's disease patients without hypokinesia. For people living in nursing homes who are dependent for care, clean teeth, unfortunately, are extremely rare. Only about 2% of all residents have clean natural teeth, and only 20% have clean dentures. Any health decline which results in an admission to hospital is associated with poor oral health. Various studies have reported that up to 90% of people who present to hospital with a range of health issues have pre-existing oral health problems. And patients with mechanical ventilation experience increased dental plaque, reduced salivary flow, and increased oral cultures, all of which are associated with a risk of poor oral health. Given the cognitive, physical, and general decline of MND patients, their dependency for care, and the use of ventilation, it would seem highly probable that MND patients would experience oral health problems. Oral health problems can result in an increased risk of pneumonia from periodontal bacteria, and this has been reported in patients with respiratory diseases, intensive care unit settings, aging populations, residential care facilities, acute hospital patients, and people who are debilitated, dysphagic, and ventilator dependent. Poor oral health may also cause halitosis, and good oral hygiene practices can reduce the consolidation of bacteria associated with halitosis and pneumonia. So oral hygiene should be an important aspect of caring for people with MND. But how do MND teams manage this? A survey of MND patients attending specialist MND clinics in the United States reported that oral care is actually very poorly attended to. 85% of patients did not receive any information or advice about oral care, and no patients or carers received any information about the relationship between oral health, oral hygiene, and pneumonia. So our project had two aims. The first was, do or don't MND patients have oral health problems? And if they do, who's most at risk? In order to do this, we needed to start assessing the oral health of our MND patients. We looked at a range of oral health assessments. We didn't consider tools to be clinically useful if we couldn't imagine applying them to our MND patients. So we excluded tools with poor face and content validity. We also considered the tools in relation to whether they had been validated against a gold standard tool. The oral health assessment tool is the only assessment that's been validated against dental examinations, which use standard dental scales, such as the Plaque Index and the World Health Organization's Oral Lesion Scale. We also considered the intra- and inter-rater reliability of potential oral health assessment tools. The oral assessment guide was validated for an oncology population who experienced different types of oral health problems, and therefore we excluded this tool. The holistic assessment tool was validated for acute care. Inter-rater reliability was so poor in their study that they didn't report it, but they did say that it was too poor to report. The revised oral assessment guide didn't report inter-rater reliability, and the inter-rater reliability was relatively low. The brief oral health status examination and the oral health assessment tool both have high levels of agreement for large populations of patients with potentially similar oral health problems to MND patients. The OHAT is actually based on refinement of the BOSSE. Specifically, the OHAT is a simplified version for easy use by a range of healthcare professionals in a range of settings. The OHAT has other advantages in that it can form the basis of an oral hygiene care plan, and there are readily available teaching and training materials produced by the Department of Health and Ageing and the South Australian Dental Service Consortium. So, overall, based on the appropriateness of using the tool with MND patients, the ability of a range of people to use it in a range of settings, validity and reliability studies, and the potential to manage oral health problems if they do exist, our team decided to implement the OHAT as routine with our MND patients. So this is the oral health assessment tool. It has 8 categories, which are each rated on a 3-point scale. A score of 0 indicates good oral health, scores of 1 indicate changes, and scores of 2 or greater equal unhealthy oral status, and the maximum possible score on the tool is 16. So between May 2013 and July this year, patients had their oral health assessed using the OHAT. These assessments were done by our clinical nurse specialist and myself, and assessments were done in our MND clinics, outpatient appointments, inpatient submission, home and nursing home visits. We also collected data on age, sex, type of MND, area of onset, ALS-FRS scores, patient location, that is, were they living at home or in a facility, whether the patients did or didn't have enteral feeding. We also collected information on oral intake, and finally information about NIV. Our study population was actually very similar to the population that Dr. Henderson described earlier. There were 61 patients with an average age of 67.2 years. We had reasonably equal numbers of men and women, and most patients had the ALS type of MND. Most patients had limb or bulbar onset. Most patients were living at home when they were assessed. Most patients had enteral feeding, and only a few patients had NIV. For the 61 patients in our study, we completed a total of 132 oral health assessments. The number of assessments ranged from 1 to 8 for each patient, and we did these assessments as part of our routine care. The average time from symptom onset to assessment was 2 years and 9 months, but there was a significant range of 1 month to 13 years. So, what did we find? 19% of the 132 oral health assessments indicated normal oral health, that is, a score of 0. 23.5% of the assessments suggested changes in oral health, and 57.5% of the patients in our study had poor oral status, which is a score of equal or greater to 2. The mean score was 2.3, the median was 2, and an interquartile range of 2.25, and the total scores range from 0 to 12. Overall, there was a high instance of poor oral health in people living with MND on assessments in this study. It didn't matter if we considered all 132 OHAT assessments or just the first assessment for each patient. We still found that just over half of the MND patients had oral health problems. So the answer to our first question, do or don't patients with MND have poor oral health, is yes. We then considered our second question, who are the 50+% of people living with MND who have poor oral health? Who should we be targeting with our assessments, intervention, and advice? So, first of all the things we didn't find. There was no clinically or statistically significant difference suggesting a greater risk for poor oral health based on age, sex, whether patients were at home or in a care facility, whether patients did or didn't have enteral feeding in place, or whether they did or didn't have non-invasive ventilation. We also didn't find that time since symptom onset increased vulnerability for poor oral health. And now for some of the trends that we did find. Total and fine motor ALS-FRS scores were negatively correlated with oral health. There was a small trend suggesting that the ALS-FRS swallow and bulbar scores declined as the OHAT score increased. These correlation plots show that as MND patients' overall level of function declined on the ALS-FRS, they were more likely to experience oral health problems, and that declining fine motor function on the ALS-FRS, which most likely relates to the ability to independently clean your own mouth, had the biggest impact on increasing oral health problems for the MND patients in our study. It has been suggested that softer diets and not eating increase the risk of poor oral health. We therefore collected information on patients' functional oral intake. We found a small negative trend suggesting that as oral intake declined, oral health problems were more likely. It seemed that the more normal the food you ate and the more you ate, the better your oral health was. In fact, consuming any oral intake, even just tasting for pleasure, reduced the risk of oral health problems. We are aware throughout this study that the OHAT may or may not be an appropriate tool for assessing oral health problems in MND patients. We found that all of the items on the OHAT contributed to the final score. This suggests that the OHAT is potentially a useful tool for evaluating oral health in MND. Our clinical observations strongly supported the statistical finding that coating of the tongue is the most significant problem for MND patients. Based on the results of our study, our conclusions are, firstly, that oral health is a problem in MND. In fact, very few MND patients actually have good oral health. Secondly, it appears that all MND patients can be vulnerable to oral health problems, but as symptoms progress, there may be more of a tendency for oral health problems, especially as limb function deteriorates and therefore the ability to clean your mouth is reduced. Oral health problems are more likely. And patients who are not able to eat or drink anything, not even taste for pleasure, may be more at risk of oral health problems. So considering the future for oral health in MND, clinically our experience suggests that tongue coating is the biggest oral hygiene problem. The OHAT only provides a 3-point tongue index, which may not be sensitive a sensitive enough measure for this symptom. There is evidence for general oral hygiene guidelines, which is what we would suggest is recommended to MND patients at this time, but we're aware that these may not be specific enough to meet the needs of MND patients. At this time, there is no research or evidence-based literature to guide oral hygiene advice and interventions in MND. We're starting to collect data on patients' oral hygiene practices and plan to correlate these with oral health outcomes. So, considering the conference themes of participation, partnerships and progress. Based on the results of this study, we suggest that we can progress better health, oral health in MND through routine assessment of all MND patients' oral health, and that the oral health assessment tool may be a useful tool for assessing oral health in MND. Questions?
Thanks, Natalie. Have questions?
Did you look at oral hypoglycemic agents? Because they could potentially affect oral hygiene. And I think also patients getting to see a dentist could be a factor as well.
Absolutely.
Sorry, the third one, I don't like asking 3 questions, but the third one is, what about actual oral thrush as well?
The study was actually initially motivated by observations of very thick tongue coating. And thick tongue coating in MND patients far beyond what I'd seen in any other neurological populations. So it actually started because I thought everyone had thrush. And so we started swabbing everyone's mouth, and they often didn't have thrush. So then we started, right, what is this problem? And this really, I think, is the beginning of investigating what the problem is. But yeah, I think it's often tongue coating with thrush and tongue coating without thrush. And the tongue coating can be very extensive and very thick. So I think we need to look a little bit more closely at that. The other questions?
The other question was more an observation about patients have difficulty getting to a dentist, but also the use of the anticholinergic medication to
drying them out
might be working against oral hygiene.
So again, this scale, it has a saliva component, but it's only 3 points. So we also have started collecting information like the saliva severity scale, and hopefully we'll be able to do some more correlations about that feature as well.
We're out of time, I'm sorry, for questions now. Thank you very much, Natalie. That was